Next topic is ulcerative colitis. It's V18 ulcerative colitis, and 25-year-old man has been admitted with 2 days of abdominal pain and profuse bloody diarrhea up to 10 times per day. He was diagnosed with ulcerative colitis 2 years ago but has not been compliant with the treatment and follow-up. What is your initial assessment and management? So history, first of all, I will ask the duration of the pain and diarrhea, frequency of bowel motions per day, associated blood in the motion, compliance to medical treatment and recent antibiotic therapy. Then I will examine him, including his vital signs, including heart rate, blood pressure, temperature, elicit any signs of shock, note if there any abdominal distension or peritonism. Investigations, so blood test, C-reactive protein, white cells, albumin, check biochemistry electrolytes, direct chest X-ray, book for hemoperitoneum, abdominal film, looking for toxic dilatation, transverse colon more than 5.5 centimeter, and stool culture for C. diff and CMV. Cautious, unprepped fluorescence microscopy and biopsies to judge extent of the colitis. An endoscopic grade of the severity. It's a Mayo classification. It's divided into 4 grades. 0, it is normal. Endoscopic features is normal mucosa, and 1, it's called mild disease activity, and endoscopic features will be erythema, decreased vascular pattern, and mild fibrillity. And then is the next grade is 2, that's moderate and marked erythema, absent muscular pattern, and fibrillity and erosions. And then is a score 3, that's a severe, and it's spontaneous bleeding and ulceration. It's called Mayo classification. And then obtained biopsies for cytomegalovirus. And then the clinical grades of the severity of the ulcerative colitis flare up. It's true love and Witt's criteria that includes bloody stools, pulse, temperature, hemoglobin, and ESR or CRP. And then each of these 5 parameters are given the score of mild, moderate, and severe. And then it's calculated. So management in this flare-up will be admission, bowel rest, IV fluid prescription, and stool chart. Withhold medications such as NSAIDs, anticholinergics, antidiarrheals, and opioids. And DVT prophylaxis, and provided results for C. diff, PCR, and CME are negative, commence IV hydrocortisone. He has been diagnosed with acute fulminant colitis and started on IV hydrocortisone 100 mg QDS. After 48 hours, how would you assess his response and what are the treatment options? So it's a Travis criteria. So repeat clinical assessment and examination of the patient as previously mentioned. Note the frequency of bowel motions per day, blood investigation including CRP, hemoglobin. If stools are more than 8 per day or stools are 3 to 8 stools per day with CRP more than 45, it would predict 85% of the chance of colectomy during this admission, and this is Travis criteria. If the patient remains, so usually we assess after 72 hours of IV hydrocortisone. If the patient remains severe and has not responded to initial treatment with steroids, options are 3 options. Either we can start infliximab, cephalosporin, or straight to surgery. So straight to surgery consideration if patient not keen for rescue therapy. Assessment at day 3 predicts with the high chance of colectomy or failure to rescue therapy. Any signs of emergency such as perforation or toxic dilatation, straight to surgery. Infliximab can be started 5 mg per kg per body day, 1 half dose in the acute setting, then week 0, 2, and 6. Assess after first dose. Option of 10 mg per kilogram for accelerated induction. And then is the cyclosporin. It's 2 mg per kg given as a continuous infusion for 7 days. If patient is thiopurine naive, assess at day 5. He then commenced on rescue therapy with infliximab. At day 5, he starts to suspect temperature and goes into septic shock. And direct chest X-ray shows pneumoperitoneum. What would you do? This patient has been perforation, so after adequate resuscitation, arrange for an emergency laparotomy and subtotal colectomy. Protectomy is usually deferred due to the prolonged operative time in unwell patient. It would be technically challenging, especially when done in the emergency scenario, and would limit the future surgical options. Endoleostomy can be matured in the right iliac fossa. Rectal stump can be either matured as a mucous fistula in the left iliac fossa or stapled close and left inside the abdomen with consideration of rectal drain, and stapled close and secured at the inferior edge of the midline wound. He underwent an emergency subtotal colectomy and endoleostomy and mucous fistula. 6 months later, he sees you in the clinic. What are the indications for further surgery and what are the options? So indications for further surgery are to avoid the risk of malignancy of remnant rectum associated with ulcerative colitis. Number 2 is relieve the proctitis symptom including anal discharge. And number 3, the quality of life, and patient may want to consider pouch consideration as the alternative to the lifelong stoma. Surgical options are completion prostatectomy and ileoanal pouch reconstruction, aim to provide patient with quality of life in terms of being stoma free. Chance of perioperative complication include 20% risk of pouch failure. Potential long-term problems include the poor function. Pouchitis may be done as one-stage or two-stage procedure involving covering loop ileostomy and subsequent reversal. Completion prostatectomy and endoileostomy. One-stage procedure avoids the future need for rectal surveillance and ileorectal anastomosis. An option for more elderly patients with comorbidities, rectal sparing disease will need rectal surveillance in the future. He chooses to have a completion prostatectomy with ileoanal pouch and reconstruction. He is planning to have a family and is concerned about sexual function. What is the anatomy of the pelvic autonomic nerves? What are the pelvic nerves involved in the male fertility that may be injured during proctectomy, and what are their functions? The superior hypogastric plexus arises from the sympathetic nerves, symmetric tongue T10 to L3, descends along the sacral promontory, then bifurcates into bilateral hypogastric nerves. These run medial to the ureter and common iliac artery, then nerves course obliquely and anterior toward the rectum. These sympathetic nerves then join the parasympathetic pelvic sympathetic nerves. The nervi regent is S2, S3, and S4, and these nerves join with the bilateral hypogastric nerves form the inferior hypogastric plexus, which is a mixed sympathetic and parasympathetic. For the male sexual function, parasympathetic innervation is important for erectile function, while sympathetic innervation is for ejaculatory function. And in the female, they called very low lubrication of the vagina. Thank you.